wealth of knowledge and insight into the field of wrestling. Just a heads up, you will not be able to unmute during this event, so please use the Q&A to communicate any questions you may have. Those questions will only show to the panelists, so we will ask those aloud after each presentation is complete. After the event, you will receive an email with the link to the quiz, and you will have 1 week to complete it. You must complete the quiz in order to receive CEU credit. I would like to extend a huge thank you to the Minnesota Timberwolves for sponsoring tonight's event. All right, Noah will intro Dr. Anderson.
It's a pleasure to talk with everybody here today. It's important that we understand as this wrestling season comes upon us here in the very near future, things to be aware of. I've been working with this for over 30 years, and issues related to skin and ear conditions are a big issue. In fact, we added the ear issue here because we haven't heard much recently about much from the public, private sector in dealing with this issue. And I'm sure it's been a big issue, whether you're from a collegiate standpoint or a high school standpoint. Skin infections we see in high school wrestlers and collegiate wrestlers is a huge issue, and the components really focus on a number of factors here. Poor hygiene, lack of medical continuity of care, and treatment guidelines not being followed. For those of you who are in the private sector and have high schools you're working with, you know exactly what I'm talking about. Those who have colleges where you have a primary doctor working with it is not as much of an issue, but even so, it still can be a big factor. Paper came out about 10 years ago talking about skin infections in high school athletes, and they looked at the issues pertaining to how much is it occurring and how often. And obviously, we look at the incidence rates and looking at over a period of approximately 5 years, and we see quite a bit of information related to the skin infections that we're seeing with a number of athletic exposures. What's interesting is that we look at the frequencies, both football, hockey, basketball. But when we start adding wrestling into it, yes, it tops the list, and that's obvious because this is a skin-to-skin issue. This is not necessarily a mat issue, it's a skin-to-skin issue. Now, as we start to look at the patterns of these infections, we see that the head, neck, and face is where we see a good chunk of these things occurring. If we look at herpes infections, 70% of them are occurring on the head, neck, and face. But if we start looking at these other areas of the body, it's important to focus on as we get away from the upper body, typically the infections become less of an issue. But what's interesting is in this paper is that they listed the types of infections seen in tinea or ringworm as being 35%. Says, okay, I can go with that. That number, studies have shown it's about right. But this paper said that bacterial infections were higher and herpes was this low. I contend this is not what we see typically. Now, case in point, in 2014, an outbreak occurred in Arizona. The high school had a huge outbreak along the state from the first part of January through March of that year. They had 47 cases of, quote, an outbreak, of which 37 were concerned from an infectious standpoint. And of those, they quantified 46% were impetigo, which is bacterial, 30% were herpes, and 5% was tinea. I looked at the numbers and said, this doesn't make sense, as this paper also does not make sense, because we look at it and anybody who's worked with wrestling will tell you that, no, tinea is by far the biggest one we see. So what was the problem in Arizona? I talked with Candace Williams, the physician from the CDC who was working with that outbreak, and she said that they received information from 30 different medical providers, and of the 23 providers who provided records, only 3 performed laboratory testing for skin issues. Meaning they only checked on, is it herpes, is it not, is it bacterial, is it not, is it ringworm, or is it not? Otherwise, it was just on their observation, which is not uncommon. But in this sport in particular, we need to take a stronger stance here and getting cultures done to verify this. And that's where the problem lies with the providers in the community. Here we have a tournament in Fargo, North Dakota. This is the Junior National Cadet National Tournament in Fargo that takes place every July, of which I've been working this for over 30 years. This year we saw over 8,900 athletes compete on 30 mats over a period of about 9 days. With skin issues developing quickly in this type of a setting, it's crucial that we have proper skin checks being performed. So, with that being said, you have roughly 1,500 kids that have to come through with certain divisions. And with that, you got ATCs who are well versed in this and doing skin checks. They know what to look for, and if notes are not appropriate, the kid's pulled. We know that hygiene is a big issue. Skin pathogens are primarily transmitted from skin to skin. As much as everybody tells you surfaces of the mat and that are great and what we're wearing is great, but these are kids who are wrestling 8 to 10 hours without showering between matches. Paper had come out showing that 2 to 4 hours after exposure with tinea on another person's body, you're going to start to infect the cells and start to develop the infectious process for ringworm or tinea, which is why it's crucial for us to really be promoting more and more of hygiene issues. And further adding the fact that these kids aren't washing this period of time, another study had showed that roughly almost 8% of these athletes are not going to shower the whole day until they go home. This is a huge issue. If anything can be done, it's important to promote these athletes to shower immediately. Skin wipes with respect to a baby wipe, cheap ones you can get at Target, doesn't matter. Kids should take 2 of them, wipe their whole body down after every single match if they can't shower. At the end of the day, they should shower quickly. If they showered after every match, it would be probably the best way to keep these infections under control. Lack of knowledge and the continuity of care. This is another issue that really needs to be driven home, especially those individuals who are working with these high school athletes. Now, what we have in the private sector is kids going to see whether it be a primary doctor, nurse practitioner, an ER, and urgent care. What we find, a paper shows that only 8.3% of primary care physicians properly diagnose primary herpes glandulorum at the initial visit. 8.3%. As all of you know, that if the proper time isn't met with respect to them staying off the mat, the risk of transmission is going to be pretty high. So a study had been done looking at this, comparing, let's say, smaller schools versus larger schools, and comparing it to, let's say, colleges. So if we look at the larger communities, what do we have for resources? You can go to urgent care, you can go to ER, you can see multiple providers at your doctor's office. And what are you getting? You're getting multiple opinions on it. So is that continuity of care? No, it's not. Let's go and compare it to college settings. What do you have? You have one doc who oversees the whole team. If nothing's right with this kid as far as it going and getting away, comes in the next day, 2 days later, it's still there, same doc's going to look at him. What happens there? You get continuity of care. So what the study showed was this, is that smaller schools, like universities that have a single doctor, have better control of this, they have continuity of care. Bottom line is that if you can, in the private sector, working with high schools, get one doctor to work with you, that individual becomes well acquainted with these skin infections. Having a kid go and see somebody at an urgent care, an ER, see their doc, see someone else at the same clinic is not good. Do everything you can to maintain continuity of care, because that is what you need to help maintain these skin infections, keep them under control. Because that provider is going to get very good at this. And I try to tell all my ATCs this, is that get good at it, see it, figure it out, and work it through. And it's amazing. It doesn't take a lot to really become very good at this. Treatment guidelines. Now, when we go to see our doctor and we get an earache or a sore throat, what do we say? You're going to be on an antibiotic for a week to 10 days, and then it'll go away. And that's fine. But does anybody ever ask the doctor, well, doc, how long is it going to take before I'm going to be clear and I won't be giving it to somebody else? Most of the time, doctors are going to look at you with deers in the head like, man, they're going to look at you like, I do not know what you're talking about. How long is it going to take for this to clear before you give it to somebody else? Why is that an issue? In this sport, it's a huge issue. So when we treat our athletes here in wrestling, we treat not only the individual, but you need to treat to prevent transmission. It's a different mindset when you're treating these kids. And so always focus on, yes, I'm treating my athlete, but what's the minimum amount of time I need so he or she is not going to be giving it to somebody else? And that is a huge difference. And most providers, if they're not aware of it, are not going to be able to follow the guidelines. They're not well acquainted with it, and that's where you're going to see the mistakes. Key point, good example, recurrent cold sores. It's a herpes infection. It's herpes simplex 1. You can get valacyclovir 2 grams twice a day for 1 day, and that is the FDA's standard treatment for treating recurrent cold sores. Is that adequate for wrestling? No. Why? Because that treats the individual, but it does not treat to prevent transmission because the virus can still be sloughed off, which is why the guidelines are typically 5 to 7 days. Anna Wald, who did research on HSV infections out in University of Washington, has commented, you need 5 days of this medication on board to reduce the ability to transmit this to an individual, which is why our guidelines reflect that. So bacterial infections, cellulitis, folliculitis, impetigo, abscess, they're due to staph infections, MRSA, or streptococcal infections. MRSA, or methicillin-resistant staph, has come on in the last 20 years, and whenever you see pus, you have to think that MRSA could be present. This is transmitted via contact with individuals. Yes, these can come from the mats. Risk increases with individuals who shave, bathing with a bar soap or bottled soap. So we look at these individuals, bullous impetigo on the lower right, a bullous or like a bulb of pus-filled material. Impetigo on the ear, we see a lot of crustiness around small scratches. And then folliculitis, where you look at the base of each hair follicle, you'll see a raised reddened area with a pustular appearance to it. Complications with bacteria, typical abscess or what MRSA. Wherever you see pus, think of MRSA could possibly be there. Going back to what we're asking, you really do need to be culturing these, because if you find it's present there, everybody knows this is a bigger issue because transmission is great, reoccurrence is great. Individuals who have a MRSA infection, you drain them, 30% of them are going to have 70% of them are going to have another reoccurrence over the next 12 months. This is not susceptible to typical antibiotics of penicillin or cephalosporins. We need other antibiotics to be treating it. Abscess is how it typically presents. Colonization is a huge issue. In fact, we do see it in the general population. We know that simple staph can exist in anywhere to 30% of the general population, a dynamic process that changes throughout time, and it can be gone 3 to 6 months later. It can exist in the nose, it can exist in the axillary area and the perineal areas. As far as MRSA, that's 1.5 to 3% of the general population have it. But 6 to 8% of collegiate athletes and 22% of collegiate athletes. It's a much bigger issue in this sport. And so when we start asking questions, have they had a reoccurrence, it's important to be aware of it, because if any kid says, I've had an abscess, well, I've had some before, you should be thinking, are we not appropriately looking at this as possibly being MRSA? Complications of this. Used to work with the Jay Robinson camp. For those of you aware of it, it's a 28-day camp for high school kids. It'd gone up until 2019. Over 30 years been going on. And we would see these all the time. When MRSA was at its height in the late 2000s, we saw quite a bit of it. So olecranon bursitis or even patellar bursitis getting infected. And MRSA was a common entity to be seen. But we also see other complications. Peyton Robb, an individual who wrestled from the University of Nebraska, 157-pounder. In 2023, as he's finishing up with the NCAA championships, he became quite ill, and it probably compromised his performance. But on the way driving home, literally driving home that night from the tournament, he developed much problem related to infection and fever and chills, he had to go into the hospital. He had necrotizing fasciitis, which is a bacterial infection, that then required him to have debridement and skin grafting in his leg. Ben Askren, a two-time NCAA Division I champion from Missouri, a 2008 Olympian and MMA champion, just this past July, and he had developed a staph infection in the skin that progressed to giving a lung infection that it required a double lung transplant. So we don't take these things lightly and thinking just put an antibiotic on board. No, it's important. We have to figure these things out, but address them acutely as possible. Herpes gladiatorums, due to the herpes simplex virus type 1. All of these different presentations you see here are all HSV1. This is skin-to-skin transmission. We know that after an athlete gets rubbed up against somebody and gets exposed, within 8 days, 90 to 93% of those individuals, if they're going to get an outbreak, it's going to occur then. Primary outbreaks last anywhere from 10 to 14 days. Facial area has a lot of sore throat, fever, lymph nodes, more extensive skin involvement, and crosses facial hairlines. What I will tell my ATCs, when you see any facial lesion, the first thing you do is you put a pair of gloves on and you start to feel for lymph nodes. If you feel lymph nodes on a wrestler who has a facial lesion, these lymph nodes in the front of the strap muscle, Highly suspicious then for being herpes. Always, always, always consider getting cultures on it. Recurrent outbreaks, typically 5 to 7 days, smaller, follow dermatomal patterns. This lower right is an individual who had been treated for years as having a recurrent bacterial infection. It says, no, this is not it. And sure enough, culture is positive for HSV1. So when we look at the primary occurrence of HSV1, to further promote the fact that this is a skin-to-skin issue, if we look at an outbreak that occurred at the J. Robinson camp in 2001, over a period of 28 days, they had 57 wrestlers who developed the infection. Now, these are kids who are wrestling 2 hours, 3 times a day, wearing a t-shirt and shorts, and showering right away after each practice. Yet we still saw these outbreaks occurring. But look at the data on here on this graph. We had nothing on the lower extremity, 0 on the left leg, and 5.3% of the right leg. But you're seeing basically over 70% of them occurring on the head, neck, and face. Why is that? Because in the late 70s and early 80s, they changed the scoring format with wrestling, which now allowed for this to be more like freestyle. And so we see more locking up in this position that you see. In fact, there was a 60% increase in this lockup position, which is why we're probably seeing most of these skin infections occurring in the upper extremities in this fashion. Lack of proper recognition is key to the rapid spread on a team. As I mentioned, 8.3% of the time, first clinic visit, they're going to be able to diagnose it properly. Here we see in this lower picture on the far right and then far left. On the far left, this is a note we received right before the tournament in Fargo in 2004. It says a wrestler can continue to wrestle. It's not contagious. Keep bandaged. I saw him 2 days later, and this is what you're seeing in this photo. Anybody here would say, I'm not going to be touching this. But this is how fast it progresses. Literally in one day, it can evolve into something this quickly, which is why it's very important to be aware of what to look for. Tinea, ringworm, is extremely common due to the dermatophyte Trichophana tonsorians. Skin primarily the means of contact from direct skin-to-skin contact. Estimated up to 70% of wrestlers in a single season can get it, but on the average, roughly 35 to 38% of wrestlers get it, which is extremely common. Here we see hair loss on the scalp. Areas under a woman had it just below her ear with the hair covering it. We weren't able to pick it up until it got to be too late. Scalp lesions and also forearm areas. Flakiness noted, slight redness noted to it. Usually we don't see a lot of swollen lymph nodes with this. Now the skin sheets here that we have in place, it's important to be aware of. I've been working on this for about 30 years to get everything uniform. And this past January, USA Wrestling finally had approval for the skin sheet. All of these rules are all in line. The only difference is in ringworm. But I think it's crucial and important to understand that whether working with the Minnesota State High School League, the National Federation of State High School, NCAA, or USA Wrestling, and now hopefully with UWW or United World Wrestling, worldwide, we're trying to make these guidelines uniform. So everybody knows whether the kid's wrestling from 5 years of age or 85 years of age. And yes, we have them that old. Everybody knows the rules are the same. So get acquainted with these rules and understand when you work with a provider that they should be using this sheet and only this sheet as far as guidelines with respect to getting your athlete back on the mat. Guidelines we have for our high school league are very comparable to what the Federation has. Bacterial minimum of 72 hours before return to practice and must be on oral treatments, not topical. For MRSA, incision and drainage is essential, but oral treatment must also be in place for 5 days before return to practice or competition. For herpes, again, a primary outbreak, oral treatment must be started and must be in place for a minimum of 10 days before return to practice or competition. For recurrent outbreaks, as I mentioned, minimum of 5 days, but 120 hours is what we go with. Now, for those of you who are thinking, well, what's the difference? Very simple. Let's say that you diagnose it at 11:59 at night, and then you go into the next day and the next day and the next day, and then that next day after that is 12:01. Well, that's 5 days, but no, it's 3 days and 2 minutes, which is a lot different than 120 hours. So the minimum 120 hours is to ensure that we're meeting what research has dictated we need to have to reduce the risk of transmission. For dermatophytes or ringworm, topical or oral treatments must be in place for a minimum of 72 hours before return to practice or competition. The NCAA rules are different along with USA Wrestling. For tinea capitis or scalp involvement, no. Has to be oral treatment, no topical treatments, and a minimum of 2 weeks. We had to pull an unfortunate individual at our state tournament last year who was on topical treatments for a month and still had indications of hair loss and indications of a carrion that had developed. The reason that we pulled the kid was because it's still considered contagious. Now we're going to jump right into cauliflower ear, or as my wife would commonly call this, why chicks do not dig big ears. She wrote an article about this for Guillotine about 15, 20 years ago. And it's important to understand that cauliflower ear, it can be prevented. If we're talking anybody going into MMA or jiu-jitsu, it's a different story, but collegiate wrestling high school is required that you have to wear a headgear. It's a significant issue, and it's important to understand its development and ways to prevent it, and also what we need to do for treating it. Wrestling itself is the sixth most popular sport, both nationally and in Minnesota. Yes, we are even more popular than hockey. We do see that the numbers are increasing considerably, and especially for women, we have a 30 to 50% increase each year for the past several years for its participation. Yet we still see cauliflower ear development, men and women. It's been noted for centuries that this has been going on. Opium dens, boxers, and most recently the past 50 years with wrestlers, rugby players, boxers, and MMA. Headgear was designed and they had been poorly fitted until things changed with new plastics in the 50s. NCAA mandated its usage in the late 60s. In present day, they're all required to wear this in competition and practice. But what we're finding is that the majority of these wrestlers don't wear them during practice, and that's where most of the time we're seeing this occurring then. So it's important to be aware that wearing it does reduce the risk of it happening, but even so, it doesn't prevent it 100%. Wrestlers don't like it, think it's uncomfortable, but I would tell you that you see this common on. It's important to be aware that once they start to get this, then continuation of a recurrence with this is not uncommon. So if we look at the ear itself, we know that basically it's cartilage, and you got skin over the surface of it. And on the top of the skin, the cartilage, there's perichondrium. That's it. Nothing else. There's no fat in there. There's no muscle in that area. So when you see the trauma develop, it's a separation of the perichondrium from the cartilage itself. Then blood accumulates under the surface. And this can happen from an impact, a fall. It's not uncommon, as someone said, my headgear even came off. We see it on football players with the new helmets where the helmet comes off and rubs the ear acutely and causes its development. And then if you let it be, what happens is on the underside of that perichondrium, between the perichondrium and the actual cartilage surface, that blood, well, the perichondrium on the underside of it starts to form new cartilage in the area. And if you let it be, it hardens. This neofibril cartilage then becomes the thickening that you end up seeing. Now, it can also, through the process of shrinking down, lead to this buckling, causing the deformity known as a cauliflower formation. So the timeline is important to be aware of. Trauma to the auricle itself causes the hematoma to form. The hematoma then starts to resolve after 2 to 7 days, but the fibrocartilage starts to be laid down in that 7 to 10 day period, and then it hardens over 10 to 14 days and becomes permanent. So you have a period of time where if you remove the blood and you compress it, you're going to be fine. If you get beyond a 14-day period, then you require plastic surgery to have it removed if that is what you want. So the treatment issues is key, let alone compression, and then don't do anything further to it. Very simple. Means of treatment upon draining. Draining it is a simple process. You take an 18-gauge needle, you put it in there in a sterile fashion, drain it, and then you have to compress it. Now, compression is different than what we've seen. Most of us nowadays would talk about suturing. What it had been in the past would simply just wrap it. That's proven to not be effective. We would do other things called a collodion cast. It takes about 45 minutes. It's a liquid, it's got ether in it, plastic, and as you mix it with the cotton and put it around the ear, you form a clamshell, but it takes about 45 minutes. Plus, obviously, with ether, it's quite flammable. Dental caulking material has come on the scene in the last 15 to 20 years, and then suturing the ear or buttoning it is quite common. People will use a dental roll or a thermoplastic splint. Drainage must be performed early within 7 to 10 days, and you can use typically an 18 gauge needle. I would not use anything smaller. And can ATCs do this? Yeah, if you get accreditation or a sign off by your physician, I have mine do it all the time if they want to. I have no problems at all with that. And then you need to then compress it. But if you start to get beyond 7 to 10 days, you're going to have to talk about whether you need to actually make an incision in there, which you can't do as an ATC, but I will do this in the clinic, pull it out, and then turn around and compress it. Key points behind all this is if we don't get enough of the blood out, or you keep putting needles in there and not do it in a sterile fashion, you can get infection in it. So hardening is quite common because a lot of times people choose not to do much about it. These magnets that are out there are also not a bad option, but it's predicated on you draining too. And they have to wear it all the time, which is why I have a problem with it, because people aren't going to wear this all the time. Compression, not enough applied to it is usually the problems, and the accumulation of blood into the void is what we typically will see. So people will drain it, say just wrap it, it's still not going to be enough. Compression is crucial for this to prevent reoccurrence. So draining it, as I said, I use an 18 gauge needle, and you basically clean it up with iodine or chlorhexidine gluconate, put the needle directly into it, and you'll drain it out. Simple procedure in draining this out, you end up seeing how it looks afterwards. Sometimes we'll drain even areas of about to 15, 18 milliliters of fluid. Some have even more than that. It's not uncommon if it's been repetitively being hit all the time and they're not doing anything to protect it. Collodion cast, as I mentioned, it's easy to apply, can be done anywhere, takes a long time, poor compliance, and the fumes are hazardous. I don't see this done anymore. I haven't seen it done in probably 25 years. Draining it and applying a compression dressing. People will put cotton to the area or gauze in front and back of the ear after it's been drained, and then put Coban or Ace Wrap around it. Here's a common issue that we would see with this being done, but the problem is the poor compliance with wearing the dressing. They take it off and there never is enough pressure. Fluid always reaccumulates. Here we talk about putting on this dental caulking. This you can purchase at through a dental supply house. You can get it on Amazon too. And the key point is once you've drained the ear itself, make sure it's not bleeding anymore, then you apply this, but you apply it in a clamshell fashion, front and back, and it compresses fairly well. If you can leave this on for 3 days and tell them not to do any more wrestling, they'll be fine. Which is why this is my treatment of choice at the end of the season when they're going to have a good 6 weeks off from a high school or collegiate standpoint before they start to get back on the mat for freestyle and Greco. I usually use a tongue blade to kind of wipe it into position here. The material itself is very thick, but it hardens in about 5 to 10 minutes, and they literally walk out the door. It's like the consistency of a mouth guard. If they can keep it on for 3 days and they just peel it off, it doesn't hurt. It just as the compression is what you need. So densely, this is what it's called. This you can get on the internet. I think each of those tubes are maybe $7.50 or $15 a piece. And the caulking device itself, if anybody's ever done caulking on windows, it's basically the same type of apparatus with respect to what you're doing to it to get it into the area of concern. Pros and cons, it's easy to apply. You got good compression, it sets fast. The problem is it doesn't adhere well. There's a cost issue, and you cannot wrestle with it in place. If you're going to put it on with a kid, you can't put your headgear on it, but it's not going to protect it. Now we start talking about suturing or buttoning, dental roll or thermoplastic splint. It's pretty straightforward. You drain it under aseptic technique, and then you turn around and you then have to anesthetize the ear and then put the suturing in with the material in place. This is obviously something that I wouldn't be recommending for ATCs to do, but I do this real commonly in my office. And once this is done, you have basically either a dental roll or this thermoplastic splint. It's like a 1/16 of an inch. And you sandwich the ear in between it. Now, the idea behind this is that you're compressing all the time. And then we can apply antibiotics to the front and back of it. And they put them on oral antibiotics for about a week. And you remove it in about 2 weeks. It does a great job. You can turn around and be able to wrestle with this in place, provided you put padding in the front of the ear and the back of the ear and put the headgear on. And it's important to be aware of, like, people who are in jujitsu or MMA, they're not going to be wearing headgears. I wouldn't put it on for them. I've had complaints, and I've had one just the past week came in. He says, yeah, it ripped out. And I said, were you wearing your headgear? Well, no, I don't do that in MMA. I said, well, that's why you had the problem. You can't keep this in place and continue on without having some other type of protection. Here's what we would do for dental roll. And, the ear's been anesthetized. As you can see, it's been drained. And so then we put the roll in the front and the back, and we sandwich it, tie it tight. The reason I'm not a big fan of this is because of the risk of infection, and they can be quite painful when they get swollen and infected around that site. And the gauze just absorbs bacteria in there. You can't really go into a shower with this at all. You can't go swimming with it, obviously, but it becomes difficult to treat. Now these, like I said, pros and cons on it. The pros, you get good compression. It's good for the outer portion of the ear, the pinna, and you can compete with it in place, but you have to put gauze in the front of it. Can be left on periods up to 2 weeks, no swimming or hot tub. Gauze is applied to the front and the back, and then the hair gear is put in place. When they're done with their practicing, they take the headgear off, they ice the area down, put on some bacitracin to it, and just leave it open. As we talk about the same thing with the thermoplastic splint, it's the same idea. The splinting material, it's thin. Usually I'll put a little bit of adaptic in between there to sandwich the ear adaptic and then the splint. And you're taking 2 loops of 3/0 nylon and basically piercing the ear and sandwiching it in between there. It's a great procedure, really straightforward. Here's actually a basketball player who had this in the upper portion of the ear. You can see this area, there's a small swelling in there. We went ahead and did the thermoplastic splint, and this is how it looks. And then we removed it 2 weeks later, and the ear looks great. It was his first time. And it was a basketball player who got bumped under the boards, but it turned out beautifully, and he's very happy with this. Like I said, you can get excellent results, especially when you catch them early with this. It's an invasive procedure. That's the one bad aspect about it. Risk of infection is always going to be a risk, and the need to be on an antibiotic for the first week is not uncommon. But I can tell you my experience with this, when this is in place, literally within a day or two, these kids are touching their ear and moving around, since it doesn't hurt at all. When I do the dental rolls, I don't quite get that type of a response. It just doesn't work as well. This is not bulky at all, and I've had better results with this. Papers have been written about this, and I usually will promote this as much as you can. Finding, though, a provider to do this, that's another story, because not a lot of people are aware of it. So who can do what? Providers or physicians, they can do any of things from the application standpoint and drainage. ATCs, drainage, application of compressant dressing, and the dental caulking, I have no problems with that at all. It's just a matter of you being comfortable with it and having your physicians sign off allowing you to do that. As my wife said, chicks do not dig big ears. And so with it, trying to promote as much as possible to keep these under control, I think is the best interest you can have for your athletes. So to conclude, from an infectious standpoint, infections are quite high in high school wrestlers. Hygiene needs to be really promoted. As I mentioned, showering, as much as it's a big issue back in my era, right now, very few people shower at schools. In colleges, it's a different issue, but in high school, no. And so what I'd be recommending is if you can get baby wipes, cheapest ones you possibly can, throw it in the athlete's bag. Tell them after every bout that you have of wrestling at a tournament, you take 2 sheets of this and wipe your scalp and every exposed part of your body. Throw it away. Then when they can, take a shower as soon as possible. Recognition of these conditions is important. I would highly recommend, try to tag on to one physician who will work with you. I think that individual, he or she, will be very well rewarded in being able to pick up on these things and be able to help the team. My ATCs are all very well versed with this because I work with them hands-on a lot. And with that, they in turn said, this is what's going on. They can send me photos, and I say, yep, this is it. We'll call on a medication for it. Education for everybody is essential. And since we have a turnover every 4 to 6 years, whether it's athletes or coaches, this is never ending. And so we have a plethora of types of educational processes out there through the State High School League. I have my own website, the Mat Doc, that has education on it, and also treatment guidelines and understanding treatment needs to focus on longer treatments that's necessary to not only treat the athlete, but to prevent transmission. With cauliflower ear, notice that the significance is huge, not only in men and in women, but its occurrence is primarily because of not wearing headgear and not addressing it when it does occur. When you do address the issue, drainage, compression, and prevent reoccurrence. Whatever you do, do not putz with it. Let it be. Put compression on it and give it its appropriate time. With that, they can continue to compete if it's treated properly. With that, we're going to address any questions that anybody may have at this point in time, and we'll be able to take time to answer everybody, hopefully.
Hi, yeah, we do have a couple. All right, can you hear me now? Perfect. We do have a question. Where do you rank using magnets in the types of compression for cauliflower ear?
The issue with magnets, first off, if you have just slight swelling, some people will use that for that and not put any type of needle in to drain. And I would leave that up to the individual because you can't get swelling without actual cauliflower deformation. But when you're starting to talk about draining the ear itself and then putting magnets on, the problem is when you look at the distributors or the makers of the magnets, they say, we'll just drain the ear and then put this on. But they don't understand is that the draining of the ear is probably the athlete doing that, or somebody with the athletic team, not the ATC, not their doctor. And then they put the magnets on, and the question is, are they going to be using them all the time? Because for good compression, it needs to be on 24/7. And I don't know a single athlete's going to be wearing those 24/7 because, well, I have to wrestle today, so I can't wear them while I'm wrestling. And they're not meant to be worn while you're competing. And so I leave that up to the individual if they choose to use it. Where would I rank it? I would rank that probably in the area of draining it and wrapping it. The same type of compliance and what you're going to get for the response. I think that if you were to drain it and put on the caulking material, it would be a better outcome than the magnets, but that would be me.
Great. What is the best way to differentiate between acne in an athlete and a more serious infectious skin condition?
That is an outstanding question. And there's some simple things I tell all my ATCs. When we see acne, what do we typically see? It's usually on both sides of the face, both sides of the back, both sides of the chest. Symmetry is the first thing. Second thing is acne just doesn't come on in a period of 2 to 3 days. It's slow to evolve and it's been there persistently, which means you need to understand and look at your athletes to understand, are they having an acne issue, and also be aware of watching for that. So it's one, symmetry. Two, how long has it been there? And three, other things of attribute. We don't typically see the sore throat, swollen lymph nodes, or a fever with somebody who's got acne. We don't typically see a lot of these other things that we might see with acne, that we might see these other infections too. But I would say the simple, biggest one would be the length of time it's been there and symmetry.
Great. If an athlete has been cleared for wrestling but still has remaining marks on their skin, whether it be from impetigo or ringworm, do you recommend we still cover them?
Issues with respect to an infection that has been, one, properly diagnosed, two, properly treated, three, met the criteria to compete. Choosing to wrap it with either Tegaderm, which is what I prefer, and then something on top of that, I would say yes, I would be. And from the standpoint that if it's a scab that's on there, wrapping it and covering it helps prevent the scab from breaking off in the process of wrestling. And so if you've met all the other criteria for treatment, and it's the right treatment and the right diagnosis, I would still consider covering it to prevent then it reopening and allow that person then get a new infection on board.
Awesome. With high schoolers, do you recommend we send wrestlers with a skin infection to an urgent care or just see their primary care provider if we don't have a doctor working with us at the school?
I usually will recommend that you get a consistent provider to work with you. The problem you run into is going to be something pops up late afternoon at practice, and they maybe have a meet in a day or two, and they need a note that night. And that's where you put in a predicament, because then you're forced to go to the ER or go to the urgent care. This is where if you have a rapport with a single physician on the team or with the team, it's going to serve you well, because that provider needs to fully understand you're going to get calls late at night. You're going to end up having to maybe address an issue after hours. And for those who are in sports medicine, I sit back and tell them, yeah, that's, welcome to the party, pal. That's just the way it is. But a lot of these other physicians aren't that way. And so going to an urgent care, as much as it's tempting, I would be inclined to say you might want to think twice about it. And I know that's easier said than done. But you're going to get a quick answer, but it may not be the right answer, which then leads to when you end up getting to see me at the tournament. I say, well, I'm sorry, but they're wrong with their diagnosis. And I said, well, this doctor said it's this. I said, I'm sorry, they're wrong with their diagnosis. So it would be better to develop a rapport with a physician that can work with you. It will save you a lot of headaches, and it'll save you from having to deal with just this situation. Because I don't know how many times it's happened. A Wednesday night, they come in, something's popped up, and they have a tournament or something on Friday, and they need to get a note, or even on Thursday, and they go to an urgent care, and they're going to get what they want, not what they need. Because the providers there are going to tell them, okay, it's bacterial infection. I got 8 more in the query to see. Here's your note. Get out of here. That doesn't do you well with respect to addressing this.
All right. How does ringworm treatment differ between different organizations? You mentioned 72 hours of topical treatment for the MSHSL, but how might it be different for the NCAA and USA Wrestling?
The treatment and the length of time is the same across the board, but the length of time that you need before you compete differs. Mm-hmm. Now, the high school league and the federation are at 72 hours. That's for simple skin, not scalp. The NCAA has gone to, if you can cover it with Tegaderm and they're being treated, that's okay. Now, why do they differ on that? And I'm going to just keep that in your mind, because then if you go with USA Wrestling, or you go with the USA Wrestling, it's going to be 48 hours. Ringworm is a nuisance infection. But does it mean we just throw caution to the wind and let it continue? No. It's the single agent that probably has been most contentious, with people saying we don't need to worry about it, and others say, well, we should do something about it because it could go crazy and just spread like wildfire. As I mentioned, 2 to 4 hours after exposure, if you don't wash it off, it's going to infect. And these kids are getting 12 hours without showering. Well, I think it's mainly going to be more reflective of the fact that you're not showering when you should be. And so with it, this is the consequences to it. So the differences exist. And I would say, one, college is probably, you have more uniform care with a provider that can overlook at it and diagnose it properly. And so they're just going to cover it with Tegaderm and let it go. With high school, we don't have uniformity. We have multiple providers, as you just said, an urgent care, primary doc, all of them, which is why we have a little more stringent with 3 days to make sure that it's being properly treated. USA Wrestling has gone to 48 hours, and the reason is because these are kids who in USA Wrestling and Freestyle and Greco, they'll go for 3-4 days or a week and then won't have another competition for another 2-3 weeks and then come back again. And so they're not there every single day rubbing up against other athletes for months on end. And so the leniency there was because there just isn't enough consistency with competition. And if it flourishes on a couple kids and they have a week or 2 off, it's going to be picked up and they're going to be able to treat it.
I feel there's a lot of, with pimple popping videos becoming really big and popular. We do have athletes sometimes that they find a whitehead somewhere on their body and they can't fight the urge to pop it. How would you try to go about that and recommend like stopping that before it? Or even if, they say, oh, hey, I popped this on my leg yesterday and now it looks funny. How would you kind of handle that situation?
Well, I think a couple things here it's important to be aware of. A pimple versus what you're alluding to is a folliculitis or an abscess on the leg. Mm-hmm. And trying to make sure that the athletes are aware of, yep, acne is quite common in your age group. And where do we know it occurs? Chest, face, and back. Acne doesn't occur on your legs. So you see something in another part of the body because most of these abscesses were seen on the extremities. They're not on the chest or on the face and that. They're mostly on the extremities. And that's we don't see acne. So the first thing I would say to him is like, no, you don't treat this as acne. Second thing is if it's an abscess on your leg or your arms, we should try to get some material to culture to make sure it's not MRSA. And so seeing your physician and asking, let's drain this, but let's also get a culture to know what this is. Because the consequences of an individual having MRSA, especially in this sport, which means everybody else in the team that he's wrestling with or she's wrestling has a potential risk of having it, and then complications as we outlined in this. And so I would say be reluctant to do any of the extremities for that. As far as, well, it's a pimple on my face, I say, you know what, I can't argue with you with that. I, again, wouldn't recommend it, but I would say it's important to understand the consequences. You may extend an infection more so. And if we didn't get culturing, that's going to hurt you and the rest of the team because we're not sure what's going on.
All right. All right. Well, I haven't had any other questions pop up, so we really appreciate you taking your time to come speak with us today.
My pleasure. My pleasure.
All right. And I think we have Tyler coming next to introduce our next presenter, Kenzie.
Hey, Kenzie, are you able to share your screen or do we need Dr. Anderson to stop sharing first?
I am pulling it up.
Perfect. Trainer with Augsburg University. She received her undergraduate degree in exercise science from UW-La Crosse and her master's in athletic training from Bethel University. Kenzie will be starting her 4th season working with Augsburg's D3 women's wrestling program. In addition, she has experience working events with USA Wrestling, covering ages 8U all the way up to the junior level. Thank you, Kenzie.
I think I just pulled it out of that. Sorry, guys. All right, so I'm gonna first apologize. I'm fighting a cold, so I apologize for any coughing that I might do. So I'm gonna talk about women's wrestling. So some of the stuff we're gonna go over is what is women's wrestling? How does it compare to men's wrestling? What are some of the common injuries I've seen with this sport? How do I stack my med kit compared to when I've been working other sports? And then now that women's wrestling is officially an NCAA sport, what does this mean? So who am I? Like it was said, I'm an assistant athletic trainer at Augsburg University. This will be my 4th season working with Augsburg's D3 women's wrestling program. I have helped here and there with their men's program. I've also done some various high school stuff. And then I've also worked some USA wrestling events. And these have had ages from like 8 all the way up to 18. So I've had my range of wrestling, but I will say with a lot of what I'm talking about today, it does kind of stay within the college wrestling just because that's what I have the most experience with. So what is women's wrestling? So women's wrestling has been a Olympic sport since 2004. In 2024, it became the fastest growing high school sport. And as of now, high school wrestling is sanctioned in over 40 states. At the college level, there's about 146 colleges that sponsor a women's wrestling program. These go from JUCO, NAIA, and then NCAA programs. Just this summer, NCAA did announce that women's wrestling would be their 91st championship sport. In the past, when we have competed throughout our seasons, we have not operated under NCAA rules. They've always been kind of close to them, but their like championship and regionals and everything is kind of its own separate entity in the past. And so now this year, that's all going to change. So at the high school level, girls wrestle under folk style rules. When you get to the college level, women wrestle under freestyle rules. And then internationally and nationally, they also wrestle freestyle. With post-collegiate, for any women who want to continue training, there are options with like regional training centers, but very few of these are women only. And many of these women have to get second jobs and stuff because they're not stipends provided. So a lot of these professional wrestlers do struggle financially. And then, so how does this compare to men's wrestling? So at the high school level, both boys and girls wrestle folk style. When you get to college, men continue wrestling folk style while women switch over to freestyle wrestling. So the difference with these is freestyle with women, they have 2 3-minute periods. And then men with folk style have 3 periods consisting of a 3-minute, a 2-minute, and another 2-minute period. Between those two styles of wrestling, there's differences in scoring positions, and then the pace of the matches can be different. So with women, there's more exposure rules, and then with men, they're more looking at control. Like with folk style, they have like riding time. Riding time's not a factor in freestyle wrestling with the women. This also means with freestyle with the women, their matches can sometimes end much faster. The tech falls and the pins tend to happen faster. So sometimes your matches can be quite a bit shorter. This can make it kind of tricky too, managing competitions, because we can have dual meets that with the men will last an hour or longer, whereas with the women, we can be done in 20 minutes, depending on how fast somebody is getting teched or pinned. Another difference is with women with freestyle, they do wrestle from the neutral position more, which is when they're like standing up, trying to get hands on each other. Whereas with folk style, for the second 2 periods, the second and third period, they can decide to wrestle in a top or bottom position. So with the women, this is where in that neutral position, this is where a lot of the injuries tend to come from. Just being up in that neutral position, there's a higher chance to get thrown, which is where a lot of injuries definitely come in. And just because you're set back up into that position, you're starting over, you're resetting for another possible injury. One of the other big main factors that a difference we see with women's wrestling, girls wrestling, because of this rapid growth, they haven't been wrestling as long. They are jumping into wrestling at the high school with boys who maybe have been wrestling for quite a bit longer than them. Or they're at the college level wrestling against some women who have been wrestling for 10 plus years, and other women who decided to start wrestling their senior year of high school, and now they're trying to wrestle in college. So that lack of experience leads to poor technique, possibly more injuries. We also see that women's wrestling tends to have less experienced coaches, whether it's the coaching is with freestyle specifically or just coaching women in general. So, and then some of the other comparisons. So there's 10 weight classes for both men and women. The minimum body composition that's used to determine weight wrestling classes for men is 5%. For women, it is 17%. With men, that weight certification and we use like skin calipers to determine this. Men have skin fold site, 3 different skin fold sites, being the subscap, the tricep, and the abdomen. Women only have 2 sites, being the subscap and the tricep. This is potentially something that should get looked at or studied more, as well as the body fat percentage. So years ago, the body fat percentage was the same, or was 12% for women. And then just last year, they bumped it up to 17. Didn't really notify a lot of people. So this did kind of mess with a lot of people's plans for their season and how they were able to weight cert for the year. I think this is something, again, they should maybe look at it more. I don't disagree that women should have it higher, but I do think, especially with last year, they probably should have like slowly raised it, just so that it wasn't such a big difference for people. And then with so few college programs for women compared to the men, their women's college schedule for the season, there tends to be a greater match volume just because of more tournaments. Whereas men usually they start the year with tournaments, and then come January, February, they do a lot more duels. Women who are doing multi-duels or multiple tournaments throughout the season, this can make it hard to return somebody from injury. With men's wrestling, it's a lot easier. If they're doing just one duel that day, one match, it's a lot easier to say, hey, yeah, they're probably good to go for the one match. That's all they have. With the women at a tournament, it could be anywhere from 1 to 7 matches in a day. So that return from injury gets a little bit trickier with the women's seasons. So some of the common injuries. So with these injuries, I did collaborate with a colleague who also works women's wrestling at the college level, kind of just asking her what she tends to see most often, as well as what I've seen. So some of this is her information as well, and just finding where we have the commonality too with our teams. So with injuries, I do want to highlight that, like I said earlier, that rapid growth of women's wrestling has led to potentially some of these women's wrestlers having poor technique or lack of experience, which then has led to a lot of injuries that maybe hasn't needed to happen. And again, with like coaches who maybe don't necessarily know how to be coaching freestyle, or how to be coaching women. And that's something I think will change as this continues to grow, as we get more research and everything. So with women, with coaches who don't necessarily or haven't had experience working with them, one of the things I think they forget about is just the different body proportions. I think they also don't take into account a menstrual cycle and how that can affect somebody's weight. With our program at Augsburg, I noticed a huge difference when they had a female coach join the staff. She was able to work with the women better on their weight cutting, making sure they're weight cutting appropriately, and then working with them when they were on their period, how did that affect them, learning how that affected them throughout the year, so then they could make sure they were looking out for what those changes might do to them coming closer to like regionals and nationals. And then, so one of the first parts of the injuries that's listed is nutrition and eating disorders. So it is a weight cutting sport. So we do see eating disorders. We do see overall nutritional and body composition concerns. This ultimately leads to irregular menstruation with some people too. At the start of every year, when we do our like pre-season screens, I have anywhere from 75 to 90% of my team that all tend to talk about having nutritional concerns or concerns about what their body looks like. So this is something we definitely keep a close eye on throughout the year. With the head and neck, facial lacerations are huge. I don't see too many with women's compared to men. I think most likely because the women just tend to head fight less than men. But when we do see any facial lacerations, I tend to see it in like the eyebrow or on the nose. And that sometimes the nose one tends to be from the headgear too. So, and then concussions, probably the biggest one for the head and neck. Some of this comes from the inexperience. Some of it's with the athletes not knowing how to be thrown when they get thrown, or not knowing how to maybe throw somebody else. A lot of these symptoms do tend to be cervicogenic in nature. So for me, I do a lot of manual therapy with neck traps, everything like that. And then because stress, and I think especially with women, I have noticed there is a little bit of a larger stress aspect with women versus men. So then making sure we're working with them with their academics too, to make sure that's not added stress. And then with the back, so cervical disc pathology. So this isn't one I've seen as much, but the colleague I talked to said she has seen a lot of degenerative disc issues. So she said she attributes this to like some of their lack of experience and then the like lack of neck strength, and so working with the coaches to make sure this is something they're working on with athletes who are newer to the wrestling. And then when we get to the back, so there's definitely a lot of costal cartilage sprains, intercostal strains. A lot of this is from throwing or anytime they're getting like wrapped around their chest, or if they're trying to rotate through positions. Like there's a picture right there of somebody trying to spin out of position. And then some lumbar disc pathology. There's definitely a lot of lack in core strength, especially for those newer women's wrestlers. So this is something I work really well on with my athletes, especially at preseason. And then we kind of work it into their warm-ups, doing a lot more core strength to try and prevent some of this from happening. And then lower cross syndrome. So just with that, always having a favorite leg or shooting leg, that kind of creates that imbalance. So that's another one we see. With the shoulder, labral pathology, usually more acute, just with extending for shots, hanging in underhooks, fooshing that foosh mechanism while they're posting on the arm. Or the biggest one I've seen too is allowing the opponent to arm bar them, where they're like really pulling that arm across. And then chronic glenohumeral laxity. So overall, I don't see some of this as much with women compared to men. Usually, I think because the women have a little bit more hypermobile joints. So they do still happen, but it's a little bit less common for the women. I do see a lot more rotator cuff pathology with women, tendinitis or sprains, usually due to that lack of experience. So I have just about everybody who ends up doing quite a bit of shoulder rehab throughout the season. And then with like AC sprains and SC sprains, these are all kind of acute. It's kind of how they're landing or getting thrown onto the mat. With the SC sprains, there's like that forced hyperabduction. So, or if they don't get down to their stomach right away, I do see a lot of SC sprains. With the elbow, definitely a lot of UCL sprains. Women just have a greater carrying angle, which predisposes them. And then also that foosh while they're posting. There is also instances while they're trying to post on the ground and their opponent will kind of be smacking at their arm to get them down. And And then that also leads into like elbow dislocations. I have seen at least one elbow dislocation every year, not necessarily my athlete, but this is something that I think is far more common, especially compared to like the shoulder and stuff. So this tends to be from getting thrown. They're trying to catch themselves. They're a new wrestler, so they don't know that they maybe shouldn't be doing that. That's kind of where a lot of my elbow dislocations have come from. And then with the wrist and hand, so there's a lot of like hand fighting. So we'll see with the thumb UCLs, we'll see lots of wrists or general finger injuries, whether it's like sprain, jam, dislocations, all from that hand fighting. We've seen wrist hyperextensions from that foosh motion, and then, or foosh landing, and then TFCC sprains or chronic degenerative, again, from that lack of strength or them reaching out to catch themselves. So with the hip and knee, I have seen a few FAIs. These are usually found partway through the season as that training is getting higher, or as that athlete is now working harder than they had maybe in high school. And then labral pathologies, I haven't seen as many of these, but my colleague said she's had 2 of these now in the past 2 years, and it's usually from the wrestler getting sat to their butt really fast, whether it's defending or attempting a throw. And then hip flexor strains are huge. There's like that picture up top of the legs being crossed. So while they're trying to like defend that position, I have seen a lot of hip flexor strains coming from that. With the knee, ACLs, MCLs, and LCLs, I definitely see a lot of those. The LCLs, I think I've probably seen more just because of how they're defending positions, or if they have an opponent who ends up cranking on their ankle and pulling that knee into the position that they're not supposed to. That is one thing where the officials are supposed to stop that ahead of time. Doesn't always happen. So I have seen some MCL, LCLs come from the athletes not getting stopped from positions in time. And then we've seen meniscuses to usually comorbidity from one of these ligamentous injuries. And then with the ankle and foot, lateral sprains, all kinds of reasons that they are getting that. It also can be like in that bottom picture, sometimes the way they're getting pulled on, that can cause issues in that ankle. I do see turf toe a lot, especially at the beginning of season. Those mats are super soft, and then their shoes don't have any support in them. So with those, it's taping, maybe a carbon fiber plate in there, and then just lots of rehab for that one. And then I have not seen a Liz Frank, but the colleague said she has had 3 cases in her couple years there, partly attributed to the shoes. They're a flexible sole, so it doesn't really protect their feet very much. So, and then between men's and women's, so obviously the best prevention is having that solid technique, building up that technique and making sure some of those coaches aren't putting those athletes on the mat before they're ready. That's something I've seen in the past where the injury happens because the athlete shouldn't have been out there wrestling. And then with it being a weight cutting sport, making sure they're managing their stress, sleep, hydration, those are all super huge. Women tend to underfuel compared to men. Not quite sure why, but this is something between me and the colleague we had noticed. And then I kind of had skin on here. I won't go over it because I know Dr. Anderson went over it. But I do tend to see a lot more fungal infections, I think, with the women than we do see with the men's teams. Same with bacterial infections, maybe more on women than men. I don't think we tend to see as many viral infections, though. But with like the fungal and bacterial, the hair has is something that we've noticed being an issue with women. They don't want to be washing their hair every day after each practice. So that's something we've had to have a conversation with them about of, I get it, your hair dries out, or you don't want to be washing it that often, but if we're washing it, we can minimize the effect of any skin issues. And then another one is shaving their legs. I do have a talk with a lot of the women at the start of the year about shaving less frequently, just minimizing the potential to have any skin infections on their legs because of any cuts or anything from that. So with my kit, and how do I stock this differently compared to when I've worked other sports? So overall with wrestling, I tend to see far more blood than when I work any of my other sports. So I do have some stuff listed here where I always have extra gauze, extra gloves. I've had a handful of times where I've almost run out of gloves at a tournament. That is, for me, super scary. So I always pack way more gloves than I ever think I need. I do use baby wipes. Those I keep Matt said with me at all times, just because using the baby wipes to wipe the blood off is far easier than using a dry gauze. I still do bring a ton of gauze with me too, copious amounts, more than I ever think I need. Same with nose plugs and cotton balls. I always have far more than I ever need. You never know. With women, I make sure to have the cotton balls too, just because women sometimes have smaller noses. So the cotton balls work better than the nose plugs. And then with like skin abrasions, I'll use Moncel's or skin lube. So if it's a small enough abrasion or just like a scratch, we can just use skin lube, wipe it right over. If it's something that's bleeding a little bit more, I use a half Moncel's, half skin lube. So it's a little bit darker from the Moncel's. It does sting a little bit, but it does tend to work a little bit better for some of those cuts that are a little bit more than what the skin lube can handle. I used to carry the Styptics. They don't make those anymore. So this year we are shifting over to the like silver nitrate sticks. I don't have a lot of experience with them yet, so we'll see after these next few years. I do bring a lot of Tearlite and like the flexible Mueller Flex Light or spatting tape. Those are super helpful for if I'm having to wrap somebody's head or a nose that won't stop bleeding. They just tend to stick better with the sweat and the hair. Making sure when you do have to wrap them, pull their headgear off, wrap around, and then put the headgear on, because that headgear can help hold the tape in place. Another one I'll tend to do is make sure, like when you stick the nose plugs up, then stick a gauze here underneath both and then wrap it all the way around. And then when I do have any of that Tearlite or Flex Light, having it in black has been really helpful, just so that you can't necessarily see when the blood is starting to seep through. It just helps if a match is super close to being over, that official's not stopping the match to make you redo a whole tape job again, just because you can start to see a spot of blood. So the black has been really helpful. I will bring PowerFlex, and I use that instead of pre-wrap for a lot of the wrists and thumbs. It just tends to hold up better for the wrestlers throughout a full day of a tournament. With tournaments, I also bring heating pads, the little electric ones that plug into a wall, because the athlete is here all 8-10 hours a day, 10 hours for the day. Maybe waiting an hour or two between a wrestling match. They do tend to cool down, especially if there's some injury where we don't want that cooling down. The heating pads can be super helpful for them. And then fannies or slings at a tournament, because those tournaments are super huge. It's not easy to carry my big kit around. They're pretty tightly packed too sometimes, so just keeping a fanny or sling on me. And then I just find a convenient central spot for my kit to stay, and try to get back to it when I can. All right. And then I will add, like, because it's there's a lot of blood in the sport. I stay away from the white shoes, only use the dark clothes, covering your face anytime somebody's coming up to you with a bloody nose or blood in their mouth or something, just to make sure you're not getting sprayed. So you're protecting yourself and your clothes and stuff too. Okay, so this, like I said earlier, so women's wrestling is now officially going to be an NCAA sport. This was decided over this past summer. So now going into this year, we do have more rules that we've been following. We've got preseason practices, which is new. There's a certain amount of practice days, and adhering to like the required days off. So some of that is new for programs this year. There's also going to be roster caps at that D1 level. So that I think will open up the transfer portal a little more maybe. There's also going to be, so we used to be with WCA as the governing body. Now with the NCAA, we switched to only 10 qualifiers at regionals going to nationals. We used to allow 15, and then there could be more than one person from each team in each weight class. So I think the change from 15 to 10 and only one per weight class will also open up more people maybe transferring to different schools, allowing them to have that opportunity to get through their whole postseason. And then, unfortunately, in the past, we have always competed D1, D2, D3 all together as one, which has been tough just with the difference in what those schools are able to do to support their athletes. Obviously, there's more money in the D1 schools, so they're going to attract the higher level athletes. This year, even though we are NCAA sanctioned, we are still staying together as one, still competing as one division. So hopefully that's something that does change and changes soon, because it's very hard to be a D3 school trying to compete against these D1 programs who are pulling in professional wrestlers or wrestlers from the Olympics. So, and then we hopefully, with it becoming NCAA sanctioned, more schools or more programs are going to start. This will obviously open up more opportunities and competitions around in our area. So like for us at Augsburg, we are the only program in Minnesota. We are the only NCAA program in Minnesota. So our closest competition is at least 2 hours away, if not a little bit more. We tend to do a lot of overnight trips. So hopefully with the NCAA sanction, we're going to see more schools close to us having programs, which will allow us to maybe do less overnights, less big tournaments, and be able to have more duels, which will then, like I had mentioned earlier, with like the difference in men's and women's, being able to have more tournaments or more duels versus tournaments will allow better or sooner return to play potentially. Ultimately, we hope for more research with this too. For myself, at least this year, now that it is NCAA sanctioned, with our ATS, I'm able to report injuries. This is something that'll go very far with research, I hope, and I hope other schools are doing this too. The more research we can have for menstrual health, the weight cutting for women, and just nutrition, body image, maybe how women with concussions in wrestling compared to men. I think any and all of that is going to be super helpful for us in the future. And then ultimately, those more opportunities for women to be able to go to school for their talent is going to be huge with wrestling, to be able to receive an education at that college level, just like any of these other sports have been allowed to do. So. All right. Any questions?
Thank you, Kenzie. We do have a couple of questions.
Mhm.
So, have you heard of a product called Bleed Cease or nasal spray with Afrin? What are your take on those for stopping nosebleeds? And have you tried it? Thoughts?
Um, I have heard about it. We have used Afrin in the past with the nosebleeds. We probably won't use it anymore just because technically what's in Afrin is like a banned substance. So with it being, and this is something where like maybe start of the season, not as big of an issue using it, but as we come into later in the season, it won't be something we'll use. I have had some athletes where the Afrin works great, and I've had others where it doesn't do a darn thing. So, yeah.
What types of foods or nutrition do you recommend for your female athletes?
Oh, geez. Um, for the women, ultimately, just eating and educating themselves on the eating. They, I think, with the women, they tend to do a lot of they will binge after the fact instead of properly cutting. So I have a lot of athletes that I've talked to about find what you like, find what fuels your body right for you, and make sure you're using that versus switching to eating whatever feels good after the fact because you can. And then you're going in this roller coaster between each weekend. So for that one, I do leave it up to the athletes with what they find works best for them for their foods. Yeah.
What things would you recommend we watch for in our female wrestlers while they're menstruating?
Um, they do tend to go up in weight, and they're young. They don't understand some of this too. So then they're getting really frustrated because their weight has gone up. They don't understand why it's up. Why it's up. They're retaining a lot of that water weight. So with some of them, educating them on it too, and I've had some where I have them log it, especially in preseason, log how their body is when they're going through menstruation or not, and what their body, how their weight, how they manage their weight during that time too. Because I think for a lot of them, the frustration with not being able to lose the weight right before a tournament really gets in their heads. And if they don't have, especially have a female coach who can help them kind of, because for me at the D3 level, we do have the coaches handle a lot of that because I'm also lucky enough to have 2 female coaches now. But letting or having those coaches educate them too can be super helpful, versus a male coach isn't going to be able to connect as well on that level. Doesn't mean they can't try and learn about it though.
How do you go about concussion protocol with wrestling? There's a non-contact practice required, but wrestling involves a lot of contact.
um, so we do have, I have it written out. I have a nice little spreadsheet. So they will go through stuff on their own in a corner, doing drills on their own. As their like non-contact day. I will also, depending on that athlete and how they're doing, they're in the middle there between their non-contact or their first contact day. I might have them just wrestle with a coach who's just going to be a little more aware of their bodies and how to protect that athlete. So I do sometimes sneak that in there depending on the concussion for the athlete. And then just slowly going up with their percentages. So we've talked about what percentage wrestling means, or like their drilling versus sparring versus going full out. And so we will usually use that too when we're going through the concussion protocol.
You mentioned mentioned you see a lot of SC joint sprains. What are your treatment recommendations for that with wrestling?
Lots of rehab. A lot of those athletes tend to be really rounded in their shoulders too. So working on loosening some of this up too, to open up that area, pull some of that stress off that joint. Heating that SC joint beforehand tends to make a huge difference for a lot of those athletes. We have little like micro lasers that the athletes can do themselves, and we can bring them to tournaments. So that's been super helpful with them too. But ultimately rehabbing back from it, and then making sure they continue their rehab with that injury. There's a lot of times with that injury, they start to feel better and they don't think they need to do their rehab anymore. And then about a month later, they come to me complaining about that joint hurting again. So that's definitely, especially with that injury, I've had to get really strict with them about doing it all season long, no matter how it feels.
Going back to some bleeding questions, because we talked about the Afrin and bleed cease. Have you tried the heel bump method, and has it worked for you?
I have not ever tried it. I've heard about it. I've read it a few times here and there, but I don't ever think of it here in the moment. One of these days, I hope I do, because I guess I've heard about it and people have had success with it. So,
I always think worth a shot if nothing else is working. So,
yep.
what do you find works best for covering and stopping bleeding on the face and lips other than skin lube?
Now that I've started using the like skin lube mixed with the Moncels, that does work pretty well. It does sting, but it goes on just like the skin lube was. It's that same consistency, but it does seem to clot some of that stuff a little bit better. And usually if I have to reapply it a second time, you can already tell the difference when I've reapplied it. The only other thing too is like if it's something really bad up on like their eyebrow and stuff, trying to cover it, which is not always ideal. Sometimes it affects their vision. But if they want to be back on the mat and be able to finish the match, you got to do what you can to cover it. And like I said earlier, using like that tear light or the like spatting tape is helpful, because it, with how sweaty they get, and the hair, those two tapes I have found work the best. And then making sure they take the headgear off so you can wrap it, then put the headgear back on, and that headgear just helps hold it in place. I tend to, depending on when it happens, have to reapply it quite a few times, but it is what it is.
Then you mentioned there was an increase in the women's body comp percentage, that it jumped from 12% to 17%. Do you know why it jumped, and any opinions on that process?
I don't know the exact reason why it jumped. I'm assuming just, I mean, women are supposed to have more fat on their bodies. So I'm assuming that's where that came in. But like I had kind of said earlier, I wish they would have slowly increased it versus making that jump right away. They also didn't announce it very well to us. So I didn't even actually know what happened. I had a colleague reaching out to me about it because they had a lot of athletes who were surprised at how their weight certs and their cutting were going to go for the year based on this jump. So I don't think it's wrong for them to have moved it up. I just would love to see why they did and wish they would have done it a little bit differently.
Are there any differences in injury time or blood time during matches between men's and women's wrestling?
Oh, I don't know if I'm going to answer this right because I don't work enough men's to know. With women's, there's not necessarily blood time. There is the 90-second injury time. And then with concussions, there's unlimited time. Usually with, let's say BJ might be able to chime in on that one. Um, yeah.
You question that again. I was addressing a different issue.
Is there any difference in injury time or blood time during matches when comparing men's and women's wrestling?
I would say no, from the standpoint, on the mat, off the mat, it's different and how it's handled. But on the mat, no, I don't see any differences. But off the mat, yeah, there is differences.
There is also the one thing with women's wrestling, with its still being new, and hopefully this will change with it being an NCAA sport this year. But anytime for our women's tournaments, it is very rare that we have doctors on site for our tournaments. When you go to a men's wrestling tournament, they usually have a doctor, if not more than one. So that's something, as like a visiting athletic trainer, it can be kind of frustrating, especially with the skin stuff. I've had multiple times where there is an athlete, because there may be ATs new to wrestling also with these new women's programs being put into place. I will see somebody get on the mat with a skin infection that I disagree with them being allowed to be on the mat, but there's not a doctor for the tournament. So then the head AT makes the decision. So there's been some of those issues in the past few years. I do hope that changes, and I hope that gets a little bit better, because it's just one of those where I'm worried about my own athletes then seeing them wrestling somebody with some sort of skin funk that I don't want them to get. So.
For sure. Okay. Well, I'm not seeing any other questions at this time. So thank you everyone for attending our event. Thank you again to the Minnesota Timberwolves for sponsoring this event. Be on the lookout for our future Sip and Study events this year. Coming up in December, we are focusing on the artistic athlete. Just a reminder, you will receive an email tonight or tomorrow with the link to the quiz and feedback for CEU credit. Ryan also just sent it in the chat to everyone. It will come to the same email that the links from the event came from. So if you don't check it, or if you don't find it, just check your spam folder or reach out to us. You'll have 1 week to complete this, and will be emailed your certificate afterwards. Again, reach out to us if you have any additional questions. Stay on the lookout for our future events. And thank you to Kenzie and to Dr. Anderson, and everyone who attended with us here on this Sunday night. Have a great night, everyone.